One common condition of the hepatobiliary tract is jaundice. Jaundice is caused by extra amounts of bilirubin in the extracellular fluid. Bilirubin is a product of the catabolism of the heme structure. Since hemoglobin contains the heme structure, bilirubin is closely associated with how much hemoglobin is being broken down in the body. When people have jaundice, their body tissue will usually have a yellowish tint. And if their skin is light enough in color, their skin will actually appear yellow, as we see here in this infant. In your life cycle nutrition class, you probably discussed jaundice in newborns that can occur for a few days right after birth. And this is for the same reason. They have a lot of bilirubin in circulation. When the babies are in the womb, the mothers remove the bilirubin for them through the placenta. And so when babies kind of have to do it on their own for the first time, it takes a few days for their organs to be able to get rid of the excess bilirubin. Also, in jaundice, we may see the change in color of the white of the eyes, and they will also appear yellowish due to the high bilirubin level. In addition, urine will appear dark yellow as well. It'll be darker than normal. Again, this is caused by the extra spillover of bilirubin from the blood, which eventually ends up in the urine. There are a few causes of jaundice. It could be hemolytic, meaning that for some reason our body undergoes the destruction of many red blood cells. Therefore, there is a large amount of hemoglobin released into the system, and this overwhelms the liver. This could be seen in any disease that causes hemolysis, the dissolving of red blood cells in a short period of time. For example, some poisons can cause this. Another type is hepatic jaundice, and this means that there is the decreased liver function that leads to an imbalance between how much bilirubin needs to be processed and how much can actually be processed by the impaired liver. And a third cause is obstruction. For example, if someone has a gallstone that blocks the flow of bile into the duodenum, then eventually the liver will not be able to dispose of bilirubin as bile pigment. Therefore, things will continue to back up, and eventually it will end up in the blood, causing jaundice. Patients may complain about it, the change of color in their skin, eyes, or urine, and clinicians can obviously observe it. So we could kind of consider jaundice to be both a sign and a symptom, but I would lean more towards classifying it as a sign because a lot of these things are observable. So jaundice is the consequence of some underlying disease. It is the result rather than the cause of the disease. Therefore, when we see jaundice patients, we need to find out why is the patient having jaundice? Which one of these reasons is it? And then focus on treating the underlying disease. Another important disease associated with the hepatic system is the portal hypertension and ascites. Portal refers to the portal vein, so portal hypertension means elevated blood pressure in the portal vein. We know that the portal vein collects the blood flow from the intestine, which is nutrient-rich after absorption. So the water-soluble nutrients enter the liver from the portal vein. However, if there is hypertension in the portal vein, then the small veins sending blood from the intestine will have a hard time doing so. Therefore, everything will back up, and eventually it could lead to a condition called varices. This is where the small veins in the GI tract enlarge or even break due to the high pressure caused by portal hypertension. So this could lead to GI bleeding, which can be fatal in some cases. So portal hypertension is a serious condition. In the clinical setting, you may see this often as esophageal varices, where there's bleeding in the esophagus, and they treat this by doing what they call banding, and basically they cauterize the veins that have broken so that they're no longer bleeding. And we'll talk a little bit about this more, but we see this a lot in people who suffer from alcoholism. Another thing that portal hypertension could lead to is ascites, which we see here in this picture. So looking here, we can see how inflated or distended the abdomen looks here. So if we're looking at the rest of the patient's body, we can see, how inflated or distended the stomach looks here. It does not look normal for their body type. So they do not appear to be an obese patient with visceral fat. I mean, if we're looking at the other body parts here, the shoulder, and then, head and neck area, we can actually see that this patient appears malnourished. We can see muscle wasting and fat wasting. However, due to the accumulation of fluid in the abdominal cavity, superficially, we have this inflated abdomen here. So people with ascites are not overnourished. Usually they are malnourished. In addition to the distended abdomen, we can also clearly see, veins here on the surface of the skin. And these we might have heard of called spider veins because they kind of resemble a spider web. So if we see this sign, we need to be thinking to check for portal hypertension or ascites. And just a side note, you may have heard of varicose veins as spider veins, and these are actually a type of varices that usually occurs in the legs, but it's not typically a result of portal hypertension. Rather, the varicose veins in the legs are caused by failing valves in the veins that allow the blood to pool. So just note that those are two different causes there. So many people with ascites have hepatic encephalopathy, which causes neurological damage. And for those with this condition, sodium restriction is often indicated, and very often they will be given diuretics to help the body dispose of extra fluid that's been accumulated. Often, as part of medical care, there is a procedure called paracentesis. And this is where they actually puncture the abdomen to let fluid out through a drainage tube in a controlled manner. And this could be in very large volumes. I've seen, 8 liters, which is over 2 gallons, come out of a patient in one procedure. And this link here is a video about paracentesis. So please take some time to review that. So as we mentioned, encephalopathy refers to the impairment of mental status. Here we see the criteria that is used to diagnose the stages of encephalopathy, and this is a common strategy in many conditions related to brain function or mental status. The exact cause or pathogenesis of encephalopathy is not entirely known. It is believed that it is due to the body's inability to eliminate certain products that are toxic to our brain. Right now, there are 3 different hypotheses about why people develop encephalopathy in liver conditions. One is the abnormal accumulation of ammonia in our system. Another is synergistic neurotoxin. as the cause of encephalopathy. So this would be the accumulation of various neurotoxins, ammonia, phenols, indoles, things like that, that are accumulating in the liver, causing issues with the brain. And the third one is that a false neurotransmitter that gets in the way of communication and leads to encephalopathy. Currently, the treatment of encephalopathy caused by liver disease is focusing on reducing circulating ammonia. To achieve this, patients may be given lactulose as well as antibiotics. And lactulose is considered a laxative to promote bowel movements, but it also has the ability to pull certain things out of the system into the lumen of intestine, and this includes ammonia that is in the blood. Therefore, by using lactulose, we can increase the fecal disposal of ammonia and therefore decrease the accumulation of ammonia in the blood. And this does work really well. It works within a day or a couple of days. You can tell if you've seen a patient on their initial assessment and they've had, a day or two with this treatment, they're much more coherent on the follow-up, and you get much better results if you're doing the education a few days later. As far as antibiotics, they work by reducing the colon bacteria that generates ammonia in the colon. So using these two things, it helps us increase increase disposal and decrease production of ammonia. So this is just a review of the urea cycle. When we metabolize amino acids, our bodies, we know, cannot metabolize the amino group, which contains nitrogen. We cannot generate energy from it. So we have to perform deamination to remove the amino group from the carbon skeleton of the amino acid. Under normal conditions, our liver will put the ammonia through the urea cycle and eventually convert it to urea. And of course, this will go and be disposed of as urine. This way, we do not have a high accumulation of ammonia in the body. Again, the nitrogenous waste is converted to urea, which is harmless and is excreted in the urine under normal conditions. However, if liver function is impaired, then it makes sense that the speed of this cycle will slow down and we won't be able to generate urea as efficiently. So we don't have as much urea, but the deamination is still occurring, and so we're still going to be having a lot of ammonia that will be continued to be generated. It is believed that high ammonia in the blood can stimulate glucagon, the pancreatic hormone, to release, which stimulates gluconeogenesis, and this leads to hyperinsulinemia because the surge in blood glucose leads to high insulin levels. When insulin levels in the blood are high, it will trigger more than just glycogen synthesis, as you know. One of the things that high insulin levels stimulates is the uptake of branched-chain amino acids by the skeletal muscle. And we know that branched-chain amino acids are essential amino acids, and their side chain contains a branch carbon chain. This increased uptake of BCAAs by the muscle could be a problem for the brain. So there is another group of amino acids, the aromatic amino acids, and they and the branched-chain amino acids compete for the same carrier across the blood-brain barrier. So, under normal conditions, the brain receives a balanced ratio of aromatic versus branched-chain amino acids. However, with the increased uptake of BCAA by the muscle, then the aromatic amino acids have less competition from the BCAA, thus leading to more aromatic amino acids in the brain. This will lead to the false transmitter production that can eventually displace the catecholamines, which are the normal neurotransmitters, from the receptors. This in turn will cause the encephalopathy. So right now, one important intervention in encephalopathy, or the prevention of it, is to use branched-chain amino acids. And there are studies that have shown that the use of BCAA can decrease blood and brain ammonia levels. Again, we know that BCAA are all essential amino acids. Therefore, to provide the patient with adequate amounts of branched-chain amino acids, if we think about food sources, we need to be providing foods that provide complete protein. In fact, dairy protein is a good source of BCAA, so this is something we should keep in mind when we consult with liver patients. This is a food group we may want to promote, along with, of course, meat, fish, and poultry, eggs, beans, and soy. Or, if they are on enteral nutrition, we may want to select a formula that is high in BCAA. This type of formula would be more expensive, but in this case, we have to prioritize and weigh the intervention against the effect, and it would make sense to use it. The next condition we will discuss is hepatitis. In this case, we are talking about hepatitis caused by a viral infection. There are several types of liver viruses that could lead to hepatitis. And we have hepatitis A, caused by the hepatitis A virus. And this is a foodborne disease, so it is transmitted almost exclusively by contaminated food or beverages. And this, you should remember, was covered in the Serve Safe sanitation class. So by following the standard precautions and procedures to make sure we don't consume contaminated water or foods, this would be totally preventable. We do have a vaccination available for the virus, which is good news. And other good news is that this virus, although it can lead to a severe condition, is totally curable. People can recover without any long-term consequences. Then we have hepatitis B, or HBV, which is another type of virus. This one is mainly transmitted by the exchange of body fluids, like blood and other fluids. Therefore, this one is a sexually transmitted disease, a STD. Hepatitis B could be acute, where the patient quickly develops symptoms or even liver failure in a matter of a few days. Or it could be chronic, and the chronic patients may not feel or report any symptoms. So they may be carrying the virus for years without knowing it, and this could be problematic because if the person doesn't know, then they won't seek treatment and they could be passing it to other people. What is more damaging in HBV infection versus HAV infection is that this type of infection can lead to cirrhosis and eventually liver cancer. So it has greater, more severe long-term impacts compared to HAV. We also have a vaccination against HBV that involves a series of shots for the initial vaccination. Then after that, the individual will have to follow up to see if the antibody level against HBV is still high enough. If not, then they will require a booster shot. Hepatitis C is usually associated with the exposure to blood or the exchange of bodily fluid from an infected person. Many people get hepatitis C due to blood transfusions, and unfortunately they end up getting blood that is infected with HCV. This especially happened in the past when people didn't realize and we didn't have the advanced diagnostic tests that we do now. So for example, many people in the 1980s were infected with HCV due to blood transfusions. And this condition is associated with cirrhosis as well. There are medical treatments and some medications that can be used depending on the genotype of the virus and how much liver damage has been done. However, right now the only true cure is a liver transplant for this condition. HCV is actually the #1 cause of liver cancer and liver transplants. Then we also have hepatitis D and E. These are uncommon compared to the first 3 types, and they usually require a co-infection by HBV to replicate. Therefore, you won't really get hepatitis D or hepatitis E by itself. So if you do have one of these 2, then you would also have HBV as well. These are acute infections that are rare in the US and are definitely not as common when compared to the other 3 we discussed. Nutrition implications of viral hepatitis include weight loss and nutritional deficiency. It is very common for people to have decreased appetite, especially in the cases of acute infection. Of course, depending on the level of liver damage, people may have jaundice as well as we just covered. We also have the increased serum liver enzymes, so the ability to handle the nutrients is compromised. When we assess patients, obviously weight and weight history is important. We want to check food intake and lifestyle factors. In the future, we will also talk about hepatitis caused by alcohol abuse, so this is not caused by a viral infection. Therefore, looking at lifestyle factors and also lab tests is important so we can see if the hepatitis is caused by alcohol or by a virus. Problems for the nutrition diagnosis associated with viral hepatitis include inadequate intake, so inadequate oral, food, beverage, and nutrient intake. Food-medication interaction is also common. And there could be the impaired nutrient utilization. This would be very appropriate considering how important the liver is in nutrient metabolism. As far as intervention is concerned, the only food restriction applied to this case is alcohol. We really do not want people with hepatitis to be drinking any type of alcohol. And it doesn't matter what type of hepatitis that they have. And this is because alcohol is a foreign molecule, so it takes priority to be metabolized. And of course, the major site for alcohol metabolism is our liver. So when patients who have hepatitis drink alcohol, their liver is very overwhelmed. And at this point, we want to make sure that the patient gets adequate energy and nutrients for liver regeneration. We know that the liver is a powerful organ because given time, what is damaged can be regenerated. Obviously, that regeneration process requires extra energy and extra nutrients to support the synthesis of new tissue. Therefore, we really need to ensure nutritional adequacy for these patients. We will continue to monitor weight change and food intake and certain signs of symptoms, for example, jaundice. We want to be monitoring if it's getting better, staying the same, or is it getting worse. So there are lab values that doctors routinely check, and it would be helpful for us to use those to monitor as well.